Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 424 of our pharmacotherapy series, which majors in adverse effects of chemotherapy and targeted agents. The next case reads, KBG, a 60-year-old woman with recurrent colorectal cancer refractory to FOLFOX, an abbreviation for fluorouracil, leucovorin, and oxaliplatin, is beginning her first course of cetuximab and irinotecan. So my question to you is, what instructions should she receive regarding the management of diarrhea if she experiences this complication? Diarrhea is a common toxicity seen during cancer treatment. It is most prevalent in patients treated with fluoropyrimidines and irinotecan. In addition, it is one of the most common side effects seen with new targeted therapies. A recent review provides an excellent summary of targeted therapy-induced diarrhea. Diarrhea is a toxicity in which patient education is paramount. Patients who do not recognize potentially serious symptoms, understand the role of self-management, or understand when to contact their provider are at risk of life-threatening consequences. The mechanism of diarrhea is not completely understood, is likely multifactorial, and varies depending on the therapy. Diarrhea may result from direct effects on the gastrointestinal mucosa, secretory factors, dysmotility, and immunotherapy-related effects, e.g. with ipilimumab, and parasympathetic effects, e.g. with irinotecan. Irinotecan can cause severe diarrhea, both early and late, in the course of therapy. The early-onset diarrhea and late-onset diarrhea appear to be mediated by different mechanisms. Unique to irinotecan, the early-onset diarrhea, within 24 hours after treatment, may be mediated by parasympathetic stimulation. Patients often report other cholinergic symptoms, such as rhinitis, increased salivation, meiosis, lacrimation, diaphoresis, flushing, and abdominal cramping as well. These symptoms can be prevented or managed with atropine IV or subcutaneously 0.25 to 1 mg. Late-onset diarrhea, generally occurring more than 24 hours after treatment, can be prolonged, leading to dehydration, electrolyte imbalances, and significant morbidity. In irinotecan-induced diarrhea, patients should promptly receive loperamide 4 mg with the first episode of diarrhea and repeat doses of 2 mg every 2 hours until 12 hours have passed without a bowel movement. The maximum dose of loperamide, that is 16 mg in 24 hours, does not apply for irinotecan-induced diarrhea. Fluid and electrolyte replacement should also be administered, if necessary. With the potential severe complications associated with chemotherapy-associated diarrhea, prompt treatment cannot be overemphasized. If a patient fails to respond to adequate doses of loperamide, the somatostatin analog, octreotide, can be used to manage the diarrhea. Randomized trials comparing loperamide with octreotide in patients with acute leukemia or those undergoing hematopoietic cell transplantation found loperamide to be more effective. Nevertheless, some evidence shows that octreotide may be used to successfully manage diarrhea associated with fluorouracil and other high-dose chemotherapy regimens. These findings have been inconsistent. Several trials in patients with colorectal cancer receiving chemoradiation or chemotherapy failed to show benefit of decreasing diarrhea with long-acting octreotide. Octreotide produces antisecretory activity in the gut and promotes the absorption of sodium, chloride, and water from luminal content. Patients should receive doses ranging from 100 to 2000 micrograms subcutaneously 3 times daily or 20 to 40 milligrams of long-acting octreotide. Although responses seem to correlate with octreotide dose, more studies are needed to determine the optimal dose. Based on current evidence, octreotide should be limited to second-line therapy for cytotoxic therapy-associated diarrhea. Other treatment options, including antibiotics, opioids, and corticosteroids, have been evaluated and are summarized in review articles. KBG should be counseled on the diarrhea that is often seen with irinotecan. She should be instructed to call her clinic if she starts experiencing any diarrhea within 24 hours after administration of irinotecan so she can receive prompt atropine therapy. Additionally, she should be given a prescription and instructions for loperamide administration and oral hydration recommendations for diarrhea occurring beyond the initial 24 hours after chemotherapy. The next case reads, CLW is a 45-year-old woman with recently diagnosed breast cancer, who underwent lymph node dissection and lumpectomy. She will receive 20 fractions, or courses, of radiation therapy to the affected breast. She will also receive chemotherapy to minimize her risk of recurrence. She is in the clinic today to receive the first of 4 cycles of doxorubicin and cyclophosphamide, abbreviated as AC. Although CLW had minimal problems with surgery, she particularly fears receiving combination chemotherapy. You counsel CLW about the most common toxicities by reviewing the likelihood and management of myelosuppression, nausea, and vomiting. CLW is appropriately attentive as you discuss these issues with her. However, her overriding concern is whether or not she will lose her hair. So my questions to you are: is CLW's concern typical of most cancer patients? How would you respond? CLW's concern regarding hair loss is typical of cancer patients starting chemotherapy. In fact, several investigators have reported that hair loss ranks second only to nausea and vomiting as a patient's greatest fear. Because hair bulb cells replicate every 12 to 24 hours, the cells are susceptible to various cytotoxic chemotherapy agents. Normally, hair follicles independently move cyclically through phases of growth, that is anagen, involution or transition, that is catagen, and rest, that is telogen. Although most persons normally lose about 100 scalp hairs a day, patients with cancer can lose substantially more. Because approximately 85% to 90% of hair follicles are in the anagen phase, chemotherapy agents may partially or completely inhibit mitosis or impair metabolic processes in the hair matrix. These effects can cause a thinned or weakened hair shaft or failure to form hair. Even mild trauma, such as normal hair grooming or rubbing the head on a pillow, can fracture the thinned hair shaft and cause hair loss. Hair loss usually begins 7 to 10 days after one treatment, with prominent hair loss noted within 1 or 2 months. Other terminal hairs, such as beards, eyebrows, eyelashes, and axillary and pubic hair, can be affected. However, these effects are somewhat variable, depending on the rate of mitosis and the percentage of hairs in the anagen phase. CLW should be informed about the expected onset of hair loss, and she should be reassured that alopecia caused by cytotoxic chemotherapy is reversible. She can expect her hair to begin regenerating 1 to 2 months after therapy is completed. The color and texture of her hair may be altered. The new hair may be lighter, darker, or curlier as it regrows. Several interventions have been proposed to prevent scalp hair loss during chemotherapy. These procedures attempt to prevent chemotherapy agents from circulating to the hair follicles with either an occlusive scalp tourniquet or an ice cap that produces a localized hypothermia and vasoconstriction. Recognizing that such devices create a refuge for tumor cells, these procedures are contraindicated in patients with hematologic malignancies and in others at risk for scalp metastases. Topical minoxidil has been studied with unimpressive results to date. CLW's concern is a legitimate one expressed by many patients with cancer, not just patients with breast cancer. CLW is likely to experience near or complete hair loss, depending on the thickness of her hair and its growth rate. She should be told how to minimize the effect of alopecia on her appearance through the use of hairpieces or stylish head scarves, turbans, or hats. She also should be referred to volunteer groups and organizations that can help her through this difficult time. Hairpieces are tax-deductible as a medical expense and are covered by some health insurance policies. If CLW thinks she will use a hairpiece, she should be advised to select a wig before hair loss begins. My next question to you is, besides alopecia, what other skin or nail changes should CLW anticipate? We will critically look at nail and skin changes. Several skin and nail changes have been associated with cytotoxic and targeted anti-cancer agents, which CLW may find disturbing. The major consequences of these toxicities are cosmetic, however, and they usually resolve within 6 to 12 months after discontinuing or completing therapy. We will now focus on nail changes. The growth of fingernails and toenails is arrested in a manner similar to hair growth. A reduction or a cessation of mitotic activity in the nail matrix causes a horizontal depression of the nail plate. Within weeks, these pale horizontal lines begin to appear in the nail beds. They are most commonly seen in patients receiving chemotherapy for more than 6 months. These growth arrest lines move distally as the nail grows and normally disappears from the fingernails in approximately 6 months. Nail changes including hemorrhagic onycholysis, discoloration, and acute exudative paronychia are seen in approximately 40% of patients receiving paclitaxel and docetaxel. Some other nail pigmentation changes that can occur after therapy with cyclophosphamide, fluorouracil, daunorubicin, doxorubicin, and bleomycin are less well understood. Brown or blue lines deposit as horizontal or vertical bands in the nails. These lines are seen more commonly in dark-skinned patients. As with bow lines, these pigmentation lines generally grow out with the nail. Standardized treatment recommendations for nail-related adverse events do not exist. Oral antibiotics and corticosteroids may be considered. Dermatologic pigment changes are among the most common and least well understood side effects of chemotherapy. Hypopigmentation has been reported occasionally in patients receiving cytotoxic therapy, but hyperpigmentation is more frequently reported. Usually, hyperpigmentation is not associated with an identifiable cause or systemic toxicity. It usually occurs after treatment with a wide variety of cytotoxic agents, including anthracyclines, alkylating agents, and antimetabolites. Most agents cause a diffuse, generalized hyperpigmentation, but the pigmentation changes can also be localized, involving only the mucous membrane, hair, or nails. Busulfan, cyclophosphamide, fluorouracil, dactinomycin, and hydroxyurea are examples of specific agents that can cause widespread cutaneous hyperpigmentation. Various chemotherapy agents can cause diverse patterns of hyperpigmentation. A peculiar serpiginous hyperpigmentation can occur over veins used to administer fluorouracil and bleomycin. Some investigators have attributed this phenomenon to a subclinical phlebitis. Hyperpigmentation has also been noted over pressure points after the use of bleomycin. Thiotepa has been reported to cause hyperpigmentation in areas of skin occluded by bandages, which may be caused by secretion of thiotepa in sweat. Interestingly, skin contact with thiotepa and mechlorethamine has been reported to cause hypopigmentation. Although hyperpigmentation reactions commonly affect the skin, some rare reactions are noted in hair. Methotrexate can cause hyperpigmented banding of light-colored hair. This phenomenon has been described in a patient receiving intermittent high-dose methotrexate and has been referred to by some investigators as the flag sign of chemotherapy. Alternatively, depigmentation of hair has been seen with several tyrosine kinase inhibitors, including sunitinib, imatinib, and pazopanib. This adverse effect is attributed to c-KIT signal inhibition leading to decreased melanin synthesis. To minimize a patient's concern regarding these pigment changes, they should receive counseling before treatment. As previously stated, pigment changes that occur in patients receiving cytotoxic chemotherapy are basically a cosmetic concern. It is important to anticipate these distressing side effects and educate patients in appropriate cases. At this time, CLW should receive counseling, explaining that these side effects may occur because she will be receiving several agents that have been implicated in producing diffuse, as well as localized, cutaneous nail hyperpigmentation. She should be reassured that pigment changes usually resolve with time. We will now briefly look at hand-foot syndrome. Some patients receiving chemotherapy may exhibit tender, erythematous skin on the palms of their hands and sometimes on the soles of their feet. Patients may also complain of tingling, burning, or shooting sensations in their hands or feet, usually not described as painful. These signs and symptoms may resolve after several days, or they may progress to bullous lesions that can desquamate. This reaction is referred to as chemotherapy-associated acral erythema or the palmar-plantar erythrodysesthesia syndrome. Agents most commonly reported to cause this reaction include cytarabine, fluorouracil, doxorubicin, liposomal doxorubicin, docetaxel, carpacetarbine, sorafenib, sunitinib, pazopanib, regorafenib, axitinib, and vemurafenib. There is evidence that the application of urea-based cream may be effective in prevention of hand-foot syndrome based on study results in patients receiving carpacetarbine and sorafenib. Both study populations utilized 10% urea-based cream 3 times daily for 6 to 12 weeks and saw a decrease in the incidence of hand-foot syndrome. Treatment is primarily focused on symptom control, and discontinuation of the medication or treatment interruption will help to resolve the reaction. After resolution, the medication may be initiated at a lower dose. Next we will look at acneiform erythematous rash. The most common toxicities reported with the epidermal growth factor receptor, abbreviated as EGFR, inhibitors and epidermal growth factor receptor monoclonal antibodies are skin-related, and are probably due to inhibition of the tyrosine kinase pathways in epidermal growth factor receptor-dependent tissues, including keratinocytes in the skin. Erlotinib, gefitinib, afatinib, and lapatinib are small-molecule tyrosine kinase inhibitors that target the intracellular domain of the epidermal growth factor receptor, and cetuximab and panitumumab are monoclonal antibodies that target the extracellular domain of epidermal growth factor receptor. These agents are associated with skin toxicities. Skin effects occur in greater than 50% of patients who receive these treatments and are dose-dependent. A pustular or maculopapular eruption typically appears on the upper body, face, and scalp in the first 1 to 2 weeks of treatment. The rashes are predominantly grade 1 or 2 in severity, may be associated with dry skin and itching, and completely resolve without sequelae when the drug is discontinued. Evidence suggests that the severity of the skin rash is associated with increased efficacy of this class of agents. In a retrospective analysis of a Phase 3 trial in patients with non-small cell lung cancer receiving erlotinib, those who experienced a rash had a significantly longer survival time than those who did not. Survival was reported to be 1.5 months in patients with no development of skin rash versus 8.5 months in those with grade 1 rash, and 19.6 months in patients exhibiting a grade 2 or 3 rash. Evidence of a correlation between skin rashes and higher response rates has also been observed in patients receiving cetuximab for colorectal cancer. Multiple therapies have been studied in hopes of reducing or preventing this bothersome side effect. Patients should be advised to minimize sun exposure and to keep the rash moist with lotions and creams, avoiding drying agents. The Multinational Association of Supportive Care in Cancer, abbreviated as MASCC, has developed an epidermal growth factor receptor inhibitor skin toxicity tool to assist clinicians in monitoring and reporting epidermal growth factor receptor-induced dermatologic toxicities. In addition, MASCC has published both patient information and clinical practice guidelines for the prevention and treatment of epidermal growth factor receptor inhibitor-associated dermatologic toxicities. Because of the prevalence and significant discomfort associated with the rash, prevention is recommended in the majority of patients in the first 6 to 8 weeks of therapy and consists of hydrocortisone 1% cream with moisturizer, sunscreen, and either minocycline or doxycycline therapy. And now let's briefly comment on dry skin. Many cytotoxic anti-cancer agents, especially bleomycin, hydroxyurea, and fluorouracil, and several targeted therapies, that is epidermal growth factor receptor inhibitors, can cause dry skin with fine scaling on the surface. Normally, sebaceous and sweat glands provide lipids, lactates, and other products that contribute to the pliability and moisture retention of the stratum corneum. In patients receiving cytotoxic therapy, the dry skin may be caused by the cytostatic effect of agents on sebaceous and sweat glands. Topical application of emollient creams may provide some symptomatic relief of this dryness. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 425.